I'd like to thank Dr. Rafi Avitzian and the course organizers for allowing me to speak today about epilepsy surgery. I have no disclosures. We know that the prevalence of epilepsy in the United States means as many as 3 to 6 million people are affected, and as many as 1 to 2.5 million people may be surgical candidates. Epilepsy resective surgery is considered in those patients who have drug-resistant focal epilepsy patients. In general, this means patients who have failed 2 anti-seizure medications. Barriers exist worldwide to getting these patients to epilepsy surgical treatment, with as many as 15 million people perhaps across the world that would benefit. Resective epilepsy surgery is elective surgery designed to reduce and/or eliminate seizures in pharmacoresistant patients while minimizing the risk of neurological deficits. We designed this surgery based on evidence gained during the phase 1 evaluation. This includes EEG data, anatomy, MEG, PET, SPECT, etc. Long-term outcomes may approach 65%. Most patients remain on anti-seizure medication. We are after the epileptogenic zone. Its basic definition is the minimum amount of tissue necessary to be excised to produce seizure freedom. Unfortunately, EEG can only measure the actual seizure onset zone. We have no way to estimate the potential seizure onset zone. The pathology involved includes commonly malformations of cortical development, neoplastic disease such as ganglioglioma or dysembryoplastic neuroepithelial tumors, hippocampal sclerosis, vascular etiologies, idiopathic or post-traumatic epilepsy. Less common etiologies that we see at tertiary centers, such as ourselves, include Rasmussen's and Sturge-Weber disease. We use traditional craniotomy and open surgery techniques. This allows us to gain tissue for pathological analysis, as well as do invasive EEG recordings to help maximize the resection. More recently, less invasive techniques, especially MRI-guided laser ablation, have become popular. We'll talk about that technique a little bit later in the talk. Common resective techniques include lesionectomy, temporal lobectomy, multilobar resection, and hemispherectomy. Lesionectomy is defined simply as the focal resection of a predetermined abnormality in the brain. This abnormality is presumed to be the cause of the epilepsy. We can resect the lesion directly, or we can take the lesion plus a little bit of surrounding cortex based on EEG or some other type of data. Examples of this type of surgery include tumor surgery, cavernoma, and focal malformations of cortical development. Here we see such a case. This is a 5-year-old right-handed boy who has a hyper-intense abnormality on T2 and flare in the periorlandic region in the left brain. This was felt to be an eloquent cortex. Here on T1, it's seen as a hypointense abnormality. Very characteristic wedge-shaped structure with a tail down towards the ventricle, suggestive of a malformation of cortical development. You see the corresponding hypometabolic region on the PET scan. Because of this, we elected to perform a subdural grid evaluation to document ictal onset as well as function. Here you see a pale area corresponding to the lesion. We placed an electrode, subdural electrode, over it. The tails get tunneled extracranially, and the patient gets admitted to the epilepsy monitoring unit, where we record seizures for posterity. We're able to do mapping, show the ictal onset on the edges of the lesion. The lesion itself splits function and displaces hand motor function more superiorly. I took the patient back to the operating room, removed the subdural grid, and resected the lesion along with some cortex on the edges. The lesson here was that this gathering of extracranial EEG data allowed a safe resection of the lesion as well as some surrounding cortex. Both of these areas were abnormal. The lesion itself was a balloon cell dysplasia or a type 2B dysplasia. The margins were a type 1 dysplasia. And so I took more tissue out than I would have done with just a lesionectomy alone. Additionally, we've learned that focal resections in eloquent cortex can be done safely. You just have to know the anatomy. The best way to gather functional anatomy is either through direct stimulation or through extracranial mapping with subdural electrodes. Temporal lobectomy is perhaps the most common epilepsy surgery performed worldwide. It's a characteristic syndrome with reproducible semiology, surgical strategy, and postoperative outcomes. Techniques vary from center to center, so that a standard resection here in Cleveland may be different than a standard resection somewhere else. There is class 1 evidence to suggest the benefit of this surgery over medical treatment. The exact technique depends on the anatomy. If there's hippocampal sclerosis, we're interested in removing the hippocampus, the amygdala, and the parahippocampus. This can be done through a standard resection, which involves removal of the cortex, 4.5 centimeters in the dominant temporal lobe, 5.5 centimeters or more, depending on where the vein of Lebet is in the non-dominant hemisphere. And then access to the hippocampus, amygdala, and parahippocampus with removal of the same structure. I try to take out at least 3 centimeters of the hippocampus in these patients. Neocortical, especially neocortical non-lesional temporal lobe epilepsy, is usually a tailored resection of temporal lobe structures based on some type of invasive EEG recordings. And then lesional temporal lobe epilepsy depends on where the lesion is. Here's an example of an MRI scan showing resection of the temporal cortex along with the mesial temporal lobe structures. There's a little remnant of amygdala left, which is often the case, and then the hippocampus resected back to the posterior edge of the brainstem. Selective amygdala hippocampectomy was designed to reduce the risk of neuropsychological deficit following temporal lobe surgery in the dominant hemisphere. First described by the son of a famous Brazilian architect, Niemeyer, in 1958. There are multiple ways to access the inferior temporal horn of the lateral ventricle to allow removal of the mesial temporal lobe structures. Unfortunately, most of the literature suggests that there is not a real benefit in the neuropsychological profile to a selective removal versus a standard removal. Here one can see a left MTS case with hyperintensity in the hippocampus on the left, atrophy of the left hippocampal volume, and a transsulcal approach through the superior temporal sulcus with removal of the mesial temporal lobe structures. Extratemporal resections are pose some special challenges to the epileptologist and the surgeon. They're a heterogeneous group consisting of patients with varied etiologies to their epilepsies. Large amounts of cortex are often involved with rapid propagation, difficult semiology. You can have a frontal lobe epilepsy with varying etiologies based on the section of the frontal lobe the seizures are coming from. Involvement of functional cortex often limits what we can do surgically. Surgical approaches depend on which part of the brain is involved and is there a lesion or not. Patient expectations are important and motivations and should be discussed prior to surgery to discuss exactly what type of risks the patients are willing to undertake to solve their epilepsy. Laser ablation has become popular. It was first approved by the FDA for ablation of neurosurgical tissue in 2007. It was initially designed to treat inoperable neoplastic disease. It causes irreversible tissue damage in the cortex from temperatures from 46 to 60 degrees Celsius. and has been, its use in epilepsy surgery has been expanding, especially for mesial temporal sclerosis and hypothalamic hamartoma. Its main advantages are that it's less invasive and allows for precise access to deep cortical structures. Using MRI thermography, we can visualize the lesion as we create it. Unfortunately, the lesion has a limited ability to be tailored. We can create a lesion of about 1.5 to 2 centimeters with a laser probe. More than one trajectory requires placement of more than one bolt preoperatively before the MRI is used in the case. Specifically in regards to epilepsy, we're not able to obtain pathology in most cases, and it's very difficult to do any kind of meaningful electrocorticography. Multiple laser trajectories can be done. However, they are time consuming, and these cases can drag on for most of the day. Here in Cleveland, I do robotic planning of our targets and entry points, placement of the bolts under general anesthesia with the patient in our intraoperative MRI suite. We pass the laser probe and then bring the MRI magnet, which is slid in on rails in the ceiling. Once the room is clear of all MRI unsafe materials, the magnet can then be brought in, and we do the thermography, the actual treatment with the laser from the control room. This is an interesting paper written by a former fellow of mine, Tandon and Felix Rosenau, looking at 43 studies, and angle 1 outcomes were achieved at 1 year in 57% of lit patients, 69% of patients treated with open surgery. Interestingly, neuropsychological deficits occurred after all of the procedure types, including lit, and the etiology associated with the best outcome was pure mesial temporal lobe sclerosis. Here's a paper published this year for University of Washington experience looking at 116 patients with mesial temporal lobe epilepsy treated by lit. 82% of them were lesional over a 9-year treatment period, and unfortunately only 37% were seizure-free at 1 year. So it's these type of reports that cause concern with the minimally invasive selective laser ablation treatment for patients with epilepsy. And so I think it may be reasonable for those patients who have pure hippocampal sclerosis and hypothalamic hamartoma, but the benefit for other pathologies remains unclear. It is less invasive, but still causes destruction of tissue and can cause neurological deficit. We use it as a first step with proper informed consent with the patient. Neuromodulation has been around for 60, 70 years or more. It has, as technology has improved and computers have improved and robotic surgery is here, its use has been increasing. The VNS was approved by the FDA in '97 in both adults and kids. The RNS, or responsive neurostimulation stimulator, or NeuroPace, in 2013 in adults, and deep brain stimulation of the anterior nucleus of the thalamus in 2018. These were all approved following randomized controlled trials that demonstrated safety and efficacy. Efficacy in this case was defined as a 50% reduction in seizures, so not a seizure-free outcome in the majority of these patients. At the same time, hospitalizations for epilepsy have increased, but lobectomies have not. And Dr. Jahai and her colleagues looked at 9 tertiary centers over 20 years and showed that the epilepsy surgeries have remained stable. The actual number for resective hippocampal surgery has declined, but surgeries for non-lesional patients have increased. So thus in 2022, SEEG, which has opened the surgical door for the non-lesional patient with focal findings. And at the same time, there's more drug-resistant epilepsy with discordant data and non-lesional imaging that are coming to the tertiary centers. We have more functional neurosurgeons who have time to focus more on epilepsy because deep brain stimulation for the other movement disorders has plateaued, and stimulation or neuromodulation has been closing that surgical loop, providing options for patients who don't have a clear-cut resective option. And I think these factors, as well as the patients at home, unable to drive, looking at the internet, they've been requesting the minimally invasive surgeries, and the industry is really pushing for their technologies to be used. However, I encourage everyone to be selective. Think about stimulation epilepsy surgery and its ability to achieve seizure freedom, which is almost zero. Resection, when possible, will always lead to a better outcome. So we use stimulation epilepsy surgery in those patients who don't have clear-cut resective options, who are unable or unwilling to tolerate resections. We use it in poorly localized or bitemporal epilepsy or generalized drug-resistant epilepsy. We never start with stimulation as the first treatment option. Remember, the take-home message is that epilepsy surgery is underutilized. If the patient has failed two anti-seizure medicines, send them to an experienced epilepsy center. I thank you very much.